Good morning, everyone. Welcome to day 3 of Interior Health Research Week. Pardon me. So good morning. Welcome to day 3 of Interior Health Research Week 2021, hosted by the IH Research Department and BC Support Unit Interior Center. My name is Kim Peek, and I work with both the IH Research Department and Interior Center as a research navigator and community facilitator. I am deeply grateful to be living, loving, and learning on the traditional, ancestral, and unceded territories of the beautiful Okanagan Nation. Let us take a moment to acknowledge all the traditional and unceded territories where we have the honor to be today. And I invite everyone to please share the names of these lands in the chat box. If you do not know the name, please take a moment to explore the link native-land.ca and then share after you've learned. Few housekeeping items. Please note that registration is open until the end of the week in case you have interest in joining additional sessions. Please also note the chat will be disabled throughout the presentation. So in about 5 minutes to give pause and time to include the territories where you happen to be. And at the end of each presentation is a question and answer period where you will have a chance to ask your questions and presenters can answer. And we'll do that through the chat box. Every presentation throughout this week will be recorded, and links to these recordings will be sent to you directly when they're posted online. It's truly an honor and a pleasure to introduce the first presentation today, titled Understanding Occupational Resilience of Frontline Workers During COVID-19, Insights from BC, Canada. And our presenters are Dr. Bala, Nikku, Assistant Professor, Education and Social Work for Thompson University, and Michelle Smith, IH Regional Practice Lead for Research and Knowledge Translation, and her portfolio focuses on long-term care and seniors care. She's also an adjunct professional fellow for the Center for Indigenous Health Equity in Australia, and also an adjunct professor for the School of Health and Exercise Sciences with UBC. Welcome to you both, and the spotlight is yours.
Thank you, Kim and Sage from Interior Health for giving us this opportunity to share our ongoing work. This is work in progress. As you have already said, the research has been titled as Mapping Social Epidemiology of BC, COVID-19 Pandemic and Psychosocial and Occupational Wellbeing of Frontline Healthcare Workers in BC. I think I don't need to highlight the importance of frontline healthcare workers in our health system. My colleague Michelle Smith and Holly Buhler, she couldn't be with us today physically. Maybe she will join us a little later. Yeah, we put together this presentation, which is work in progress. Stay tuned. We will be making another presentation in December 2021, hopefully by the end of our research project here. How do I change my slides? How do I change my slides? Is like this. Okay. I have, thanks to my institution, Thompson University, for giving me this opportunity and my colleagues there. I can't name everybody here today, but I would like to kind of acknowledge our main funders of this particular research project, the Michael Smith Foundation for Health Research, which actually gave the primary funding, and the KGH Foundation also kind of gave us a little top-up foundation fund later to continue with many more number of interviews that we would like to do. I also like to acknowledge our institutional partners in Interior Health, Island Health Authority, Hospital Employees Union, and BCNU. Without their support, this research could not have taken place. I also acknowledge my team members, Professor Mohammed Tahid from TRU Computer Science Department, Dr. Mohammed Ibrahim from UBC Social Work Department, Dr. Graham Dodd from Thompson Region Division Family Practice, and Rhonda Eden also from Division, who is our main collaborator, and student assistants, Dennis Peck, Gian Albutra, and Yasmin. Without their support, again, this research could not have taken place. However, this is a collaborative effort. If there are any errors, as a principal investigator, I'll take the responsibility and I'll try and do the justice. So thank you once again. Basically, we thought we will kind of make use of this presentation around 30 minutes, making use of the feedback that we would like to have. Yeah, basically we thought each research is contested and political process. So me coming from human services and social work, I take research as a contested space, but also very powerful and challenging, especially when we can influence policymakers and policy making, which could actually bring a lot of impacts in our lives. And with that kind of context, we have kind of very clear aims that we can set for this presentation and the whole of research. We have a mixed methods research kind of paradigm here. You might find it very interesting. We'll spend some time on that. To me, it is a methodological innovation because coming from social work, I'm very much attuned to a qualitative, grounded, narrative kind of inquiries. But I kind of, thanks to Holly and Michelle and other colleagues on this project, who are experts from quantitative and also human analytics or digital analytics or computer-based analytics. So we brought kind of different methodologies, methods to this particular research that becomes exciting and powerful. And we would like to present preliminary results we've been analyzing and it's still going on. And finally, we want to come back. What is this all telling us, when it comes to a policy application, especially how can we make a difference to healthcare workers? Because this whole research is about their occupational well-being and their resilience. And because we know that, they're the cornerstones or the building blocks of the health system that we are kind of talking about today, which becomes very important, especially a COVID-19 pandemics and other disasters. So this is the kind of outline that we will follow. We will take about 30 minutes and we will more than welcome question and answers. We really need critical feedback and suggestions to make this research take it forward and also make it useful for our policymakers. As I said, we will spend some time on the whole context, because context influences the way we design, the way we think, the way, So the whole research is being basically a rapid response call of Michael Smith Research Foundation. Last year, while we are all in the middle of the COVID-19 crisis, we don't know what's happening. The whole world is like panic, kind of mode. This is the time. Me coming from racialized immigrant backgrounds from Asia, I've been reading about, newspaper statements and signs, a lot of journals. I think the whole thinking, our lives is basically around COVID-19. So this is the time that we actually put together this proposal and got funded. And some of these statements like this really kind of stuck with me. I think that made me to think, what is that we can do, from an interdisciplinary, transdisciplinary kind of, expertise that we have here in BC. So when you see, a family come together and, children don't know what's happening. I have 2 kids, the same thing here. Why we use masks, why I shouldn't go to the school, why we have to be, isolated, why we are not meeting friends, why, all this, So how do I make sense of myself and my family? And there are many stories like this. At 6 p.m. Saturday, a particular family sat for their dinner and the family is silent, because my younger daughter do not know what's happening. And the husband here, whose wife is a nurse, her partner is a nurse, she's in tears and hurting inside, and I cannot get up and hug her and console her because we are very worried what happens, the transmissions and the unknown factors. I'm frustrated and I'm in tears now, the father, I feel her pain. I know how hard she worked today to save others' lives, putting her own life at stake, and the conditions that her facility were not ideal. And, these are the statements already telling us about the lives that we led or leading even now, the organizational cultures, the places that we work with, people that we work with, all that influences our well-being. So that was the kind of, context that this project actually came up. And my other Indigenous colleagues spent weeks with our family making, sewing masks for elders and fellow workers. We know what happened to personal protective, equipment. So basically there are all these, emotional, factual, media hype, media statements, racialization of pandemic, stigma, discrimination. I think this is not the first time that we all, hearing about this, but COVID-19 basically brought, I think, a very large, very real facts, actually. Again, we also saw news statements like, some of the health workers left, from the pandemic pay or, facilities or support systems. There are so many, including social workers like me. So again, this brought us, I think, divisions in our society, in our workplaces. Me coming from social work and anti-oppressive, social work, power, politics, how do they kind of, come in play in our workplaces is very important. So many of us left kind of alone. We haven't given resources, and there are maybe political, choices that people made that, again, I think, kind of added to our well-being and mental health when we come to work. You must have seen. So from there, we wrote these 3 questions. Basically, this is what our guides are research. We wanted to understand the job satisfaction. We wanted to understand the burnout levels. We want to understand how prepared our healthcare frontline workers now and in the future. We also want to predict so that, as academics, I think we have models to predict these behaviors so that we can actually help our policymakers better. So to study the level of job satisfaction, burnout levels, preparedness by frontline health workers in home care and long-term care facilities in BC, and how we define frontline healthcare worker is basically anybody who come in contact with our clients in the last 6 months or 1 year. We define them as frontline healthcare workers. So to meet this objective, how prepared are our frontline health workers in responding to COVID-19 crisis and future epidemic outbreaks in BC? How do we predict the future outbreaks in kind of BC? This is where the digital or the computer, analytics come in hand. So that leads us to the second question: how are our social networks? Because we are all part of these social networks, and social networks does influence the way we make choices. And we also influence social networks that we belong to. And we wanted to understand how are these social networks that we are all, kind of part of, or we are isolated for some time. How are these networks impacting the service delivery of frontline healthcare workers in BC? Basically, why we want to ask this question, because we want to build descriptive and predictive models using agent-based models and social interactions. Again, it's my colleague, Prof. Heath, is an expert. Unfortunately, he couldn't be here. Basically, this is a third level of our analysis, which I'll talk about in a minute. But we will be able to answer or build, descriptive and predictive models so that, we can predict the human behavior or healthcare, workers' behavior and their, preparedness and future outbreaks. Finally, we want to recommend policy strategies. That's what I think we are trying to do today as part of knowledge translation and synthesis. Research should not be lying in the, in the libraries, and it should be useful for our policymaking. I think BC has an example right there. So we want to recommend policy strategies to achieve an enhanced health inequities. I think this is the core that brings resilience, that brings, kind of well-being. So we want to kind of contribute to the discourse of health equities in BC and especially key populations like frontline health workers in BC. So what health equity measures are in place? So we have these 3 questions. To answer these 3 questions, we came up a kind of an anti-oppressive critical race kind of research approach. We wanted to do 2 things. We want to understand their occupational well-being. We also want to understand the social well-being. So because these 2 things together, I think help us to understand resilience at workplace. Again, there's a lot of theoretical models to study resilience at workplace, like effort, reward, imbalance model, job demands, resources model. So basically, we have done a very in-depth literature review, and we came across many models. Especially, we took these 2 models, especially the job demands resource model. This comes in 1996 from I think a German medical sociologist, Segrest, who actually says that this received much attention in the health and occupational studies because it's predictive power. These models can help us, the predictive power and adverse physical and mental health outcomes. Basically, this model tells us how to identify the unfavorable psychosocial work characteristics. I think that's what you will see in our results that focus on mismatch between the cost going to the work and delivering my care my duties, taking care of families and other carers, and the gains that I receive, both intrinsic and extrinsic, the rewards that I gain by doing this work, and the costly social transactions. This is like a social justice. We all operate in that kind of dynamics. So this model especially helps us. Basically, this model has three components: the efforts that we make, the rewards that we expect or like to gain, and the over commitments that we make, which is actually influencing our well-being and resilience. So this is one model. Again, I don't kind of intended to do a lot of presentation on the research presentations, but I think this particular model captures what I said a while ago. What happens? There are a lot of job demands, especially COVID-19. I think changed the way we work. That brought a lot of job demands, new skills, and we all working in precarious conditions. I mean, healthcare workers are basically working in those conditions, right? We know that. And it has mental, emotional, physical, and other demands, maybe newer demands that came up with the lack of, kind of rewards or lack of, job security or employment security. And we can also mobilize a lot of job resources like support, autonomy, feedback, maybe self-care, and maybe other spiritual and cultural and social networks. So there are a lot of job resources that we could mobilize. I think we do all this. When job demands are high, what we do is we kind of bring up with some performance production strategies. What does that means? That you will see in our analysis. Basically, we want to perform, we want to protect our jobs, we want to protect our clients, we want to do the best. And healthcare workers are the best, So we all do the strategy adjustments, maybe we'll narrow the attention span, we increase some kind of selectivity, or redefinition of our task requirements. I think we saw all that is happening in healthcare. And we also come up with some fatigue after effects, risk choices, high levels of subjective fatigue. Again, we do all this maneuvers, and that might lead to a reduced health or energy, or less resilience, maybe more vulnerability. So when job demands are high, rewards are less. At the same time, my reduced health, energy, mental health, that leads to a negative organizational outcomes. But there are job resources are there for me to cope up, and there's a high levels of motivation. There will be positive organizational outcomes. I could explain more, but I think basically what I'm making here is by looking at this, jobs, demands and resources and efforts and rewards. There are more efforts and less rewards. Of course, there is an imbalance. There will be a stress and leading to burnout. So this is the kind of, again, there are a lot of scales that we could mobilize, impact scale, or basically we also looked at scales like I have made some notes here. There are many different impact event scale, or basically a Marsh burnout scale, or Woodenberg burnout scale, Bergen burnout inventory. I mean, there's a lot of scales. We haven't used a particular scale, but these scales during our review of literature did influence our thinking. And the questionnaire that we came up with 3 sections with 46 questions were influenced by all these scales. So with that, as I mentioned, we used a mixed methodology, an online survey to capture quantitative, aspects of the well-being and resilience demands and the demographics. We also have qualitative interviews, basically using, kind of a grounded theory model here. And I mentioned that we will be using some computer analytics to explore social network analysis and also agent-based models, which we will not be presenting it today. We will be presenting it today, our survey results and also preliminary results from our qualitative interviews. And we are trying to kind of make some sense out of here. As you can see, 623 total responses we received through RedCap, which is again a very secure online system. Basically we have about 438 responses that we could analyze. These responses, kind of captured between June and August 2021. Though the research has been funded middle of the last year, we got all the ethical clearances by March 2021. RedCap survey and piloting, all that took time, and well, luckily we have time to capture a huge number of respondents here. There was a great demand, and thanks to our DCNU and a hospital union, support, and of course, Interior Health and other partners. We have completed 18 qualitative interviews, and I think the kind of results now are very interesting. I think it's kind of popular assumptions were questioned when I looked at this data a couple of weeks this month. So who are our respondents? They all came from different geographic regions. We asked a question. This doesn't mean that they're working for that particular health authority, but they are in that particular health region. As you can see there, there's a lot of, of course, representation from Island Health. But I think more interesting is like we were able to capture diverse, frontline healthcare workers. As you can see, registered nurse, healthcare aides, allied health, LPNs, and all others, the radiographers, the technicians, many others, we put them into other. So we were able to capture a diversity here. Again, you can see our frontline workers are registered nurse, cardiac registered nurse, medical radiography technologist, CT supervisor, X-ray technologist. Yeah, I mean, we were able to, capture results, survey inputs from a wide variety of frontline health workers, which makes our results very robust. And I think our analysis becomes interesting here. We also looked at the age and other demographics here. I think this also tells us very important, who are these people talking to us. As you can see, of course, about almost what? 90%, 95% are females, only very few male respondents that we have. If you look at the age, again, it's very interesting. I think right from 30 to 39, 40 to 49, 50 to 64. 30 to 64 is the major. I think it comes about 37, 25. Yeah, it's about 80% of our respondents actually are in the 30 to 64 very productive age group there. We also have a very younger, 18 to 29, as you can see here. So again, we when it comes to demographics, the respondents, we were able to capture right from 18 to a very young, very beginning in the jobs, and also very seniors and maybe 65 plus. So again, I think we were able to capture diversity here. We also looked at their identities. The larger assumption is that healthcare work, especially frontline healthcare work, is vulnerable, low paid, ununionized, mostly, very precarious and less paid. And you have heard, media statements. I believed in that. But the results was basically showing that 83% of our respondents actually come from identified as white, and about 18% identified as non-white. That includes East Asians, Indigenous, Latinos, and Middle East Asia, South Asia, Black, again, a range of, people. So basically about 18% of our healthcare respondents came from non-white, but surprisingly 83% are from this particular, identity. And we also had a question. We wanted to know who are all these people again, because again, their status, their location, their privilege, their skills, all that matters when it comes to, when we are looking at workplace resilience, right? So we also asked another question, is your spouse partner currently working? Again, you can see there, 58% of our respondents said yes, and 27% of our respondents said not applicable. Maybe they don't have a partner, they don't have a spouse, or they're single. That is telling us something. That means about 30% of our respondents are single or prefer not to answer. So again, what we are trying to say here is our demographics does show a very diversity of skills and racialized and also, living patterns. We also have another slide here, which tells again, have you been evicted in the living situation in the last 12 months? Only 6 people said yes. That means these things are happening. Some of the health workers are very, very vulnerable, and we could actually take who are these 6 people and what kind of responses they have. So we are not presenting it today, but we have the ability to actually go by, these kind of, statistics, which will help us to kind of predict and also, come up with some models. Working hours, we looked at it. And again, We have not changed, but for some it's changed. Whether they laid off, yes. 6 people said yes. Took leave of absence. About 10% of our respondents took leave of absence as a coping mechanism, perhaps. So again, there's a lot of interesting ideas there. We also asked whether you're exposed to COVID-19 at workplace. As you can see, surprisingly, I think 42% of our registered nurses said yes. We might think that, healthcare aides might be more in direct contact with their clients, and it's only 24% of the healthcare aides said yes, they were exposed. But overall, I think if you can see, at least 30 to 40% of our workforce actually been exposed to COVID-19 at workplace. I think that is telling us something already. And we asked some more questions. For example, are you concerned about increased risk to your family members, of course, and also other networks that belong to friends and others? Again, as you can see, extremely concerned, 16%, 18%, 13%, 24%. So about 25% were extremely concerned, moderately concerned. Basically, as you can see, 75% of our health force naturally are very much concerned about these risks at their workplace, to the families. This is telling us already something. And now we kind of put that model, ERA model there. We want to understand what's happening in their workplace. And this is the kind of statements we received from our qualitative interviews. I would suggest, everyone takes Ativan, just kidding. I like this humor that brought into our interviews. I think people need to treat one another with respect and how they would like to be treated. It sounds very simple and straightforward, but I think it would be a long way in my department. As you can see that it may not be happening, I would say that my relationship, for most part, between my supervisor and myself, professional and healthy. I think my relationship with my colleagues is great for the most part of it. So again, we have that mixed results here because people tend to commit. And when the rewards are not compared to the effort that they have invested, there is risk of health. And we have seen that already in those interviews. And again, the time of interview also matters. Whether we had these interviews last year, maybe it would have been different. I'm sure our interviews in the couple of weeks after October 12th, where I think there are other, health policies that are coming into effect, the vaccine passports and other stuff. So where we are, at what point we are, also influences our thinking and our, so we kind of capture. What we are saying here is we see very mixed results there, as you can see from our quantitative survey also. Do you feel comfortable raising health and safety concerns with your authorities? Again, interesting, right? At least 1/3 of our workforce are having difficulties to raise these health and safety concerns, which is, I think, interesting finding for our health bureaucrats and health planners. Why are they, hesitating? What are those structures? Who are these gatekeeping people? Why are they, not able to, open up? Are they being part of unionized, non-unionized? So we can again see who said no and why are they saying no, and we have also kind of so again just below kind of work culture, I have some more kind of key quotations here. My relationship with my supervisor and colleagues at my workplace is professional and not too friendly. I don't see my supervisor regularly and do not see most of my colleagues outside of my work. You can understand what's happening right there. There's a little support because co-workers added stress and also paranoia to daily duties in work and environment. I think they're talking about the shifts and the kind of support they used to have prior to COVID-19. Also, they spoke very openly and negatively about individuals who feared, were not ready to get vaccinated. As you can see, all these discussions that are happening in our workplaces that are impacting our way of working. So then basically we went on to if this is what's happening, what kind of self-care strategies that our workforce, are able to practice. I think I'll skip this. What happens around us also impacts us. So this is what they said. What is happening on workplace also coming to the family arena. They say, of course, much better. In the last 12 months, my work situation has made many of my relationships with my family and friends better. That's a good news. Again, LPNs, they haven't said anything. Healthcare aides, 4% of them at least said better. Maybe they have a social network supports, or maybe friends, maybe they received better support systems from the workplace. Maybe policies are working for them. But again, somewhat worse, as you can see. So there is a mixed results there, how these things are happening. We have some more results here. What happens? Again, I brought some quotations. Maybe I'll just leave it there. We make these slides available to all of you. I think this is another interesting when it comes to especially burnout and workplace resilience. Over the last 2 weeks, how often have you felt little interest and pleasure in doing work? As you can see, nearly every day, 13% of the people said they kind of felt a little interest and pleasure in doing the work. As you can see, very exhaustive already there. I feel used up at the end of the workday, 33%. I feel emotionally drained, 28%. This is already telling us basically how depersonalizing, in our workplaces, and how less engaged or how difficulty to engage now, and also bring that motivation, So I think, again, 44% of, people said, in my work, I deal with emotional problems very commonly. That's the good news. So that means they're able to mobilize some of those expertise skills as frontline care workers, but at the same time, several days, they also have issues. I feel energetic while providing care to my clients. Again, nearly every day, 15%. So we see those mixed results. Some of those, I think, colleagues have really shown extreme levels of, vulnerability or burnout, and at least, 1 quarter, kind of actually doing very well. So we can actually separate these, attributes from the analysis and see what made these people so special. What are the other, social support mechanisms or, workplace resources they were able to mobilize that actually help them to be more resilient, and we should be able to say very interesting findings there. Coming to self-care, again, people have mobilized different strategies, changing jobs, no time, my childcare responsibility during this pandemic have increased, so I'm struggling. Again, in between shifts, I often work out, go to gym, adequate amount of sleep. I also bought a Peloton in March that helped me with increasing my exercise. I do not have to go to the gym now because I could buy and put it in my home. I also spend time with friends. Again, I think people, care workers have mobilized different strategies. We also talked about racial victimization. We also saw some evidence there. I think, leave it there because it's already 34 minutes. Do you feel appreciated? This is very important again, because I think the more social transaction, the more you are appreciated, the more societal recognition you mobilize, the better, you will be able to deal with the situations. Again, we saw mixed results there. Initially, healthcare workers did receive a lot of recognition, but now it is kind of slowing down, it seems. No, people don't realize that we contact positive, patients multiple times a day, and I feel nursing and doctors are always being recognized, whereas no one really stops to think about all the allied health professionals. So we can understand who are not being recognized. These are like unsung or hidden heroes or whatever. So we can actually, again, see who's saying this and how can we kind of understand, and reach out. So these are some of the highlights from our quantitative analysis and quantitative, interviews. I invite my colleague, Michelle Smith, to kind of summarize and also kind of reflect what all this means to IH or other health agencies, and we kind of open them question and answers. Thank you so much. Michelle.
Thank you, Bala. So I will bring forward, and I just enjoy talking to you. Now you want me to talk, okay. I'm calling in from the ancestral territorial unceded territories of Sioux Nation from Kelowna, BC. And to summarize all the great work that Bala has been doing, the qualitative interviews, occupational resilience is dwindling down. Care workers are feeling drained about wearing the constant use of the PPE, the personal protective PPE, and excessive hygiene and hand washing protocols, which we know are very important, but at the same time is quite draining, and it's a lot for them to do every day, all day, and they're working a lot. They're working in constant fear of being exposed to COVID and bringing home to their loved ones, negatively affecting family relationships. So the whole dynamic right through from your work culture right to your home. Increasing levels of some form of burnout and showing negative work features as a coping mechanism, switching roles, changing jobs, changing responsibilities in the last few months. And I think, as we know, it's been going on for quite some time, and people are switching out and leaving, and that's causing quite a crisis, increased crisis for staffing. As you know, it's a dire situation at the moment, and people are feeling it. With the Quality of Interviews Day, we'll continue on for a few more months till the end of the year, and then also the quantitative. We're going to have the online survey running again, so we have matching online quantitative survey with what's being said at the same time as these new rollouts of changes in policy are happening. So that will be a stay tuned as well. And next slide, Bala. You can switch. I want to just touch base about how we connect with researchers like Bala. So in the IH research department, so we're bridging research in the healthcare sector. That's our main goal, and how we work together, collaborating on research and quality. So what we look for, what we want, and what we try to support is what's driven by the needs and priorities of the healthcare sector. We want evidence-based research. We want to know what's going on, and we want to have impactful information that we can move forward. The inclusive voices of people receiving care, those that provide care, their families. So we want to know direct from the source what people's perspectives are, what's happening, and so that we can help move that from the research piece into the quality, into operations, healthcare across BC, the different health authorities and the ministry. And in this way, because this is a question that operations, leadership, health authorities, organizations want to know, is how can we impact policy changes? And this is the way we can do that. They need to know the evidence in order to actually make the decisions moving forward that actually can hopefully make changes. And then the opportunity for this study for IH and across BC is the voices of the healthcare workers on their quality of life, the health and work life, the health and well-being, racism, burnout, positive, negative experiences, and impact of COVID. That's just a summary of what we've pulled through for this study. And that in turn can inform policy, how we communicate, how we can support and positively impact the staff in context of healthcare sector. And that basically, it all comes down to how do we meet the needs and how do we do that? And people like Dr. Nikku and the IH can come together and figure out what we can do moving forward with actual in-time research. The best we can do is work together, know what we need, know what researchers need, and inform as fast as we can, because we're always running behind the game. So time, as fast we can get input, time mid findings and the findings, as fast we can get information and be involved in what's going on, the better we can support. So thank you. Bala, would you like to see anything else before we wrap up?
Yeah. Thank you, Michelle. That's wonderful. The summary, you made, I can't do better than this. Basically, what happens from now on is like as Michelle said, the online Red Cap survey is on. Again, we want to capture, sentiments or responses or how our healthcare, workforce is feeling right now in the few months. And then qualitative interviews will go on. And then we also all this data will be fed into my colleague, Dr. Tahid, using a computer analytics net logo or project, So when we feed this information into these softwares, I think we can actually make some modeling. I think that will be an interesting feature of this particular research. We should be able to predict who are from our healthcare, from the attributes or from the data that we have. Can we say who are these people, or what race or what age, what demographics are doing well and why? And how can we actually change the behavior, where we have to change? Is it the reward system we have to change, or the resources system we have to change, or the self-care measures we have to change? So if we can provide these, attributes to these agents, and also we can come up with, some kind of modeling. So I'm not an expert on that. I'm willing to learn. And for our next presentation, we should be able to come up with these models by then. So Stay tuned, and we welcome your contribution and your feedback and your suggestions. And now the session is open for question and answers.
Thank you, Bala and Michelle. And we're already getting questions in, which is great. For our attendees, we have opened the chat box, so please feel free to enter your questions in there. The first question we have is, what analytical techniques are you doing?
Yeah, looks like this is, I think, about methods that we are using. Basically, we are using, as I said, online survey, which is a quantitative survey, and I've shown you some analysis there, descriptive tables, descriptive analysis. We will be doing some, bivariate tables and more complex tables. That's from the survey, and from qualitative research interviews, we already are doing some kind of grounded theory, open coding and Excel coding, and kind of come up with some kind of phenomena. What's kind of put together all this when it comes to occupational well-being and resilience? What is the kind of major phenomena that is affecting all this? So we will be using grounded theory analysis for our qualitative interviews. As I said, the third is most interesting to me, at least, is the computer analytics. What I call it. What the scholarship talks about is agent-based modeling and also social network analysis. By doing these techniques, we can actually predict the future behaviors of these care workers. We can also predict or assess, say that what are these networks, how these social networks are functioning, what are the networks that healthcare professionals or respondents that we've reached out to be part of, how are they influencing these networks, how is this information is flowing. So this is, we haven't presented today, but these are the three major analytical tools that we are using.
Thanks, Bala. And question number 2, first of all, it's a thank you for your presentation. And could you comment how COVID impacted the recruitment process for your research or during your research?
Michelle, could you answer that?
In a couple of ways. So initially it was delayed a bit longer just to get things going and kind of change up how we're going to be doing the recruiting, because from the beginning of the year, this year, it was surprisingly, and we had a lot of hesitation about putting the online survey out. We thought no one is going to, we'll be lucky if we get 50 to 100 people, and we had nearly 200 in a week. Like, that is why we went to KGH Foundation and asked if they would be, and applied to see if we could get extra funding for additional honor and gift cards to extend out the survey, because if people wanted to answer it that badly, then we wanted to make sure it was available. And then the qualitative surveys, they've been starting since September, and they're starting to progress. And so that, of course, is a little bit harder because people, so they contact us if they want to participate, and then we work out. They work out the time that works for them. So that is definitely more of a challenge, but it's off time, and it's a phone call or a Zoom link if they wanted to.
Yeah. Just to add, I think these things would have not been possible without Dr. D. Taylor from IH, who actually behind the scenes, and also colleagues from VIHA, colleagues from BCNU, colleagues from Hospital Employees Union. I could never think of such a collaborative effort, that brought us this few, findings, you may say. But yeah, we are in the process, and as Michelle said, it took quite some time to get these ethics research, approvals, because many collaborators across BC, so this is my first time in a Canadian research space, and yeah. So I hope what I'm trying to say is very complex, very multi-layered, but I think we are all passionate, and the results, I'm sure it's going to help our health professionals and health policymakers to look at.
Great. Thanks, guys. So the next one is kind of a three-parter. So I'm going to say it. It's more of just questions from you guys and in general. So it's I think the literature is clear, and your study shows that burnout is happening. ... Question is, how do we intervene? This could be a rhetorical question. And then also curious, you feel like the process of having healthcare workers share their experience is also part of their healing. So research becomes the vehicle for change itself. So what do you guys think of that?
Thank you. I mean, the second part is actually happening. I have statements saying that, and it's very therapeutic. Oh, thank you guys. Nobody speak to me for 1 hour, so patiently, so empathetically. Again, I think this is where, as I mentioned, we brought those stories, narrative inquiry or, narrative analysis and kind of grounded theory. So it felt very therapeutic, and people sometimes went on to more than an hour, Initially, it is very difficult to get their time. Again, thanks to Hospital Employees Union, Lisa there, she kind of reached out, and they're working different shifts, and lives are complicated, and you need a real time to really talk to somebody, right? So thanks to my research students who kind of reach out to these people. We do interviews whenever they want, at whatever time they want, weekends or, in 2 parts. So it's very therapeutic, it's working. Thank you, whoever asked that question. Yeah, it's happening. Research is powerful.
I agree with that. An additional question. Could you each comment about how Michelle's role supported this research?
Without IH colleagues, I don't think we would have been able to come to this so far, Michelle is the practice lead. I've learned so much from her. As I mentioned, I'm from social work. I'm not from nursing or from health. I've learned everything from, basics, how the system works, how many, long-term care homes we have, what is the structure, who works there, what are those policies, everything, she's my teacher there. And maybe Michelle, you can explain your own role. And again, Holly, our data expert, she taught me a red cap survey, and yeah, I can't just mention how collaborative learning that took place within the team. Even my research students, they mentioned how to do systematic reviews. We're getting a paper on systematic reviews. How epidemics or pandemics happens. This is not the first time it happened. And how race is being, politicized and racialized pandemic, management. We are getting a paper on that. Gian is working on that. Denise herself is a care worker. Jasmine is also a care worker. They bring their own lived experiences to this research and also learn, different skills. Like I'm learning new skills, it is easy to say mixed methodology, but it's very difficult. I have to understand, different paradigms here and collaborate and agree and have patience. Oh my gosh, so yeah, Michelle did play a key role as an expert here.
Yeah, and I could just add to that. So part of what we can do, because I've done the work previously also with and currently with the healthcare workers, and so sometimes it just depends like what your portfolio is within the health authority and what meshes, and so I can help provide some context for things like that, and then I can also help with what Bala was saying with kind of what the kind of layout is and what's going on, and find people, because we understand too in the Ontario Health or other health authorities, it's very hard to find who you should be talking to, and not because you don't necessarily bother to check. It actually is literally hard to do. So we understand that. So people like myself or Kim or Sage or like Holly can connect the dots, people to you and figure out what and getting the information forward. And so when leadership operations are asking for something which meets this, then we figure out and we translate it back, transfer it back, and they can use that to impact what they're doing, or at least the input, right, along with everyone else's input. And so that's really what we do and what we want to do, if that makes sense. We try to, and I worked on the outside from university in before, so I understand it can be challenging, but we want all of the information. We want evidence-based, we want it now, and we like so whatever we could get for it.
Thanks,
thanks, Michelle. Just to add, we also have a plan for 2 knowledge translation activities. One with our community of practice, like our care aides or the frontline care workers alone. We want to share these details or the findings with them and also triangulate with them. BCNU colleagues and the Hospital Employees Union, Lisa, will be on board, and we will be kind of sharing and open to criticism and feedback. And also do one more with our experts and the key stakeholders in the health sector. And finally, we bring all this together. And of course, again, No research is, I think, 100% proof, but yeah, we try to find the truth, what's happening, and how can we really improve the occupational or workplace resilience of our frontline workers in any way that we can.
That's great. I'm going to paraphrase this question a bit because I'm assuming that the word they means healthcare workers. So it's, will your next survey ask what forms of recognition they, and I'm assuming healthcare workers, would appreciate?
Good question. Yeah, I would love to ask, but any changes that we make with our questionnaire or interview, checklist, we should go back to research ethics to get the clearance, which is again so helpful and so supportive to us. I'm not sure what my team will say. Yeah, but that we could do in the interviews, maybe, perhaps. Yeah.
Yeah, it would be helpful to understand what, because that is a important factor, and I've heard that before as well in different contexts, that getting that personal or individual group what recognition really can help.
That's where the grounded methodology is helping us. Like, we can go back and ask new questions till we get that, theoretical saturation. So perhaps we could, I think we will do this. And even though we don't do this, people will come up with this latest, or recent, events that are affecting their workplace and family, and networks anyway. So this will reflect in our qualitative interviews. We should be able to capture that.
Great answer, guys. All right, one more, or well, we do have some more time. I'm curious, are the survey questions from existing literature, or do you guys design them?
Yeah, interesting. Thank you for asking this. We designed and we tested, as I mentioned, somehow coming from social work, maybe my disciplinary background, I'm a kind of anti-oppressive, structural, kind of researcher. So those scales are so useful. We could have used one of those scales and kind of, analyze. But sometimes the scales are also kind of obsolete, and sometimes we can't really capture what is happening, right? And COVID-19 pandemic is very unique in that sense. And there are some scales that are available, but we actually came up with the questionnaire, the questions in the questionnaire after deliberating and pilot testing. Yeah, so we basically coming up. We are not really constricting a new scale. We could have done that, but yes, the questions we kind of constructed based on the feedback and also from the literature and and from the comments from the Research Ethics Board.
And this is something else connected to research ethics. Where are you storing the collected data, and how are you going to disseminate the results?
Yeah, maybe Michelle is a good, to answer this.
In a secure, password-protected location on the server for the Thompson University, and as well, we have it's also safely secured in a Teams workspace for the team piece, where it's removed to work on separately. But that is how we're storing it. And what was the second part of that? Oh, disseminating. Yeah. So there's a couple different pieces. So as we progress further, it's reporting back to Interior Health as well. There's opportunity for, the plan is to have the participants involved and open to other care workers as well, and then organizations leadership. And the plan is written reports, but as well a panel discussion, and we plan for more meetings, but it's just for COVID. So now there's going to be like one main one at the end to discuss the findings and learn from that.
In addition to that, of course, workshop presentations and conference presentations and formal publications, and also, faculty present. I can see 2022 is full of presentations for me. But most interestingly, taking these ideas, to the classroom and also share. This is what's happening. What do you guys think? So yeah, I'm interested in disaster social work or pandemic social work. I work with wildfire, in BC, and also earthquakes and floods in Asia. So there's a lot of ideas coming from this project, and I want to thank again Michael Smith Research Foundation for believing in us and supporting this.
It's wonderful. When I don't see any more questions, so I'm just going to selfishly have a moment. I was really, and I guess my heart was happy to see all the stories you guys have. And I'm sure that that richness and honesty will come through in your KT deliveries. And it'll be such a wonderful reflection for the communities that you've connected with, so with the healthcare worker communities, to be able to see themselves reflected in that data. So that's really lovely. I realize I haven't been a frontline worker for a long time now, but I do recognize that these times are extremely stressful, and so seeing themselves reflected in a way that shows the heart of the matter is just lovely, and yeah, makes my heart happy to see that. And I really look forward to hearing more of what's to come. I realize that this is a phased approach, and you guys have more still to do. So we look forward to reconnecting with you and sharing as you guys move forward.
Thank you, Kim. That's kind of very encouraging words, Oh my gosh, you made my heart warm now. So ask me any more presentations, we are signing for it.
Awesome.
Again, thank you so much, all the participants, and we would love to have your feedback. If not now, I think these slides will be made available, and we are open to receive any suggestions. And again, we want to make this research useful and powerful for our care workers.
Absolutely. Yeah, and all sessions this week are going to be recorded. So we're going to share the recordings once they're posted online. And for attendees, if you would like to be connected to Bala or Michelle, feel free to email me. My email's under my name, so under my head, or you can email research@interiorhealth.ca and we can facilitate that connection, no problem. Thank you so much, Bala and Michelle, for the great presentation today. Thank you. And I recognize we have 4 minutes until the start of our next. So we're going to have a brief pause, brief bio break. Please feel free to get up, stretch your legs, get a drink of water, and then we can come back refreshed and ready for our next presentation. Thank you so much, and we'll be back.
Reagan, how come you're under Nelly's name?
I'm not sure.
This is Kim. It could just be the link that you entered in on, which is okay. If you're not able to change the, perfect, to change the name yourself, you're good. Just a heads up, everybody can hear us. So I'm just going to mute my line. Feel free to write to all panelists in the chat, and we can talk that way. And at exactly noon, I will introduce you guys in your presentation. All right, welcome back, everybody. Thank you for the pause. So for those just joining, my name's Kim Peek. Welcome to IH Research Week 2021. Just a few housekeeping items. Please note that during the presentation, the chat box will be disabled, but at the end of each presentation, there's a question and answer period where we open the chat box back up and you're able to type your questions in to communicate with the presenters. Every presentation this week will be recorded, and links to these recordings will be sent to you directly when they're posted online. It's a true honor and pleasure to introduce our next presentation of the day, titled Understanding the Impacts of Climate Change Hazards and COVID on Mental Health in BC Rural Communities. Our presenters are Dr. Nelly Oelke, who holds many hats, including as a researcher and associate professor of nursing with UBCO Okanagan, and Dr. Carolyn Szostak, who's an associate professor of psychology with UBCO and also holds many hats, and Reagan Zinck, who is also with the UBCO psychology portfolio. And we welcome you all to IH Research Week, and the spotlight is now yours.
Share my slides. Okay. Sorry, are you seeing the presentation view? Okay, great. Not the notes. Okay, great. Thank you. Thank you, Kim, for inviting us and introducing us. So I am Carolyn Szostak. I'll be co-presenting with Nelly Oelke and Reagan Zinck. So to begin, I'd just like to acknowledge that Nelly and I are presenting from the unceded territory of the Silks Nation, while Reagan is currently on the homeland of the Anishinaabe, Haudenosaunee, and the Huron-Wendat. Our research team is quite diverse and consists of people from a variety of UBC Okanagan and UBC Vancouver departments, different institutions, and also a couple of people who join us from Australia who work at the Centre for Rural and Remote Mental Health. In addition, we are collaborating with a couple of community research assistants and a number of student RAs. And we have been fortunate to receive funding from the IURC Tri-University Partnership Research Fund, and also the multidisciplinary undergraduate research projects in health. And certainly without both of those sources, we'd be much more limited in what we're able to do. So just to give you a little bit of background for research, certainly over the last 5-10 years, and even starting before then, we have been experiencing diverse, catastrophic, and recurrent climate change hazards of a variety of sorts. So depending on the region of BC, communities have been widely affected by wildfires, catastrophic flooding at times, drought, and as most of us can attest to, extreme heat during some of the summer months. And these various events are well known to impact physical health in a variety of ways, but they also can significantly impact the mental health functioning of people. And so, for example, individuals who've experienced wildfires directly may develop signs of post-traumatic stress disorder. There's also evidence that depression and anxiety is increased, both during and for long periods afterwards. Substance use is oftentimes reported to be increased. And as well, there are reports of increased suicidality. Again, this change can take place during a climate change hazard, but also the increased risk of suicide persists afterwards. More recently, or just at the time that we were getting ready to start this research, BC and the world was affected by the COVID-19 pandemic, such that on March 18th, BC declared a state of emergency related to the pandemic. And while this has devastating physical health impacts, it also has severe and persistent impacts on mental health. And again, these impacts are being seen to be quite persistent. So for example, research by the Mental Health Research Canada, a charitable organization that really focuses on improving the well-being of Canadians through research. They found during the very first wave of the pandemic that Canadians who report high levels of anxiety, that the number of those Canadians had actually quadrupled. And in a similar fashion, the number of people reporting high levels of depression doubled. More recently, they just released results from their 8th poll, looking at the state of mental health during the 4th wave of the pandemic. And here again, they've found that the evidence that the incidence of increased stress, anxiety, depression is persisting at elevated levels. But they've also reported some interesting emerging findings suggesting that the status of mental health varies as a function of whether one has been vaccinated or not, with greater distress associated or being experienced in those who are not vaccinated. So our research also really focuses upon the experiences, the impacts of these various events on one's mental health. But we're focusing on individuals who live in rural, remote communities within BC. And in this regard, it's important to keep in mind that these are communities that are both disproportionately and inequitably impacted by both COVID and also climate change hazards. So for example, many of these communities oftentimes have more limited services and supports available to them. The services, the agencies that do exist often have more limited collaborative relationships that again can limit access to these services. Many rural, remote communities experience higher levels of stigma related to mental health concerns. And also there's oftentimes a higher level of poverty. So certainly there is a growing body of literature that focuses upon mental health related issues, but there's been very limited research in these communities looking at the impact of COVID and climate change hazards. And so we're interested in trying to understand the impacts of these two contexts, both independently and also how they work synergistically. So our research is guided by two objectives. First and foremost, we're really seeking to understand at a deeper level the mental health impacts of climate change hazards and COVID in rural BC. And in this regard, we're focusing primarily on 3 communities, Ashcroft, Burns Lake, and Karameas. However, we have extended the research to include community members who throughout BC living in a rural community. Our second objective is to use this understanding to develop community-based solutions that are really designed to foster community resilience. So just a little bit about the 3 communities that we initially targeted as our primary focus. These are communities that are relatively small. Their population ranges from about 1,500 to 1,800. And there are some similarities, but also differences. So Ashcroft, as you can see on the map, is located just a little bit northwest of Kamloops. And in terms of climate change hazards, they've experienced a variety of them, including wildfires, the impact of associated smoke, drought, and also extreme heat. Burns Lake is located